Well, thank you so much for the opportunity. I'm here to talk about some research that I've been doing over the past few months that has been sponsored by the um, NSDA, and I'm very excited to have some preliminary data to show today. So I'm actually going to pull up some slides here if I can figure it out. And this is a little bit of an informal slideshow, but hopefully can demonstrate some pictures, just talking about the concept of the study, setting it up, and then showing some of our preliminary results. So this, I think everyone in the audience or everyone here knows the adductor laryngeal dystonia as an isolated task-specific focal dystonia. The critical aspect here is this is disabling to many individuals, and our current therapies, while good, aren't great. They're invasive. They require repeated visits to a physician and can produce side effects as well. And so the primary one being Botox that's demonstrated here. So the goal is to learn more about laryngeal dystonia, what causes it, with the ultimate goal of altering or improving therapies for those affected in the future. A tool that we use to measure this and to look at the brain function in patients with neurologic disorders, which of course adductor laryngeal dystonia is resting state functional MRI. And so this is a tool that measures blood oxygen levels in the brain. It allows us to look and determine how specific regions of the brain interact. And so that we know that there are specific regions of the brain that control movement, control language, control other aspects of how we function. And we can really use this tool as a spotlight to hone in on the areas that are affected in patients with disorders. And there are prior studies performed using this technology, resting state functional MRI, to take pictures of the brain in patients with dystonia. Those studies have been promising in that they show both global, the entire brain and how the entire brain communicates, but also focal, specific regions in the brain and how they have dysfunction and don't act normally in dystonia. There are some challenges with that, and I'll talk about those in a second. And then, of course, there is data in patients who have undergone botulinum toxin therapy injections. So we can take pictures of patients before and after Botox, and other groups have done this and demonstrated differences in the brain as a result of that treatment. And so this, of course, gives us clues as to which brain regions are involved in the improvement in those who are affected by various forms of dystonia. This has been done in cervical dystonia. This hasn't been done in laryngeal dystonia yet. So this is one of the goals of this project, is to apply these methods to patients with laryngeal dystonia. The studies, the approaches that I just mentioned are primarily done at a group level. We get a whole group of patients with laryngeal dystonia or other dystonia. We apply the imaging techniques and then we average those images out. So there are drawbacks to that approach, meaning that we don't get the individual specifics. A patient with dystonia is not another patient with dystonia. We know that everybody with dystonia has different symptoms. They have different ways that the disease affects them. And so we suspect that the brain and the dysfunction of the brain is what contributes to those subtle but meaningful differences for the patients. And so by taking a group and averaging that, it gives us a clue. It helps to shine that spotlight a little bit, but it doesn't really allow us to shine that spotlight even more in a more focused way in that individual affected by dystonia. So we're developing methods that allow us to really look at the individual, the unique person with dystonia. And prior studies, in addition to grouping data, have also done a very poor job of accounting for potential errors that can occur in MRI data. And so patients with dystonia, people in general, healthy patients, move when they're in the scanner. We breathe, we take a deep breath in, and when we're lying in the scanner, our head moves, and that can account for distortions in the pictures, right? So if you move your camera when you're taking a picture like this, you're going to have a blurred image. Same thing in the MRI. If the target's moving in the MRI, we can't see that as well. And so many of the studies to date have not accounted for that movement and have not allowed us to do that. And so the risk with that is that a lot of the results that we have in existing literature and existing studies of dystonia are errant. They're actually a result of that movement and not so much a result of the dystonia, for instance. And so we've shown this in prior data in dystonia Here, the details of this graph aren't necessarily relevant, but demonstrate that effect of movement, where there are a lot of false positives when we don't account for movement, meaning that these results aren't reliable. And then when we eliminate that movement, then we start to get down to the real nitty gritty, the actual regions of the brain that are involved. So this study that the NSDA is supporting is really designed to overcome some of those limitations. First, we're going to study adductor laryngeal dystonia. That's a task-specific dystonia, as opposed to cervical dystonia, where the cervical dystonia occurs when patients are in the scanner, and that can cause some of that head movement. Adductor laryngeal dystonia, patients can lie in the scanner still relative to the other forms of dystonia. So that gives us an advantage to look at the brain without the other confounds. And then again, I mentioned we're going to study individuals. We're looking at the specific individual's brain map in patients with laryngeal dystonia. And we're doing this with two specific aims. The first aim, we want to determine the voice-activated somatomotor, or the network of functional significance in individuals, a single patient with this disorder, adductor laryngeal dystonia. And if we can do that, then this allows us to really start to hone our future research efforts, our future efforts towards treatment. For instance, neuromodulation. If we can stick a DBS electrode in the exact spot in that individual that's dysfunctional, that may be much more beneficial than just shooting it towards where, on average, people are affected. The second aim is to determine if treatment, in this case botulinum toxin injections, if this alters the individual patient's map with respect to their functional connectivity in the brain as we're measuring. And of course, this has implications, again, with respect to treatment. We have an understanding of, in the current available treatments, when it works, how does it affect how the brain communicates? And perhaps in understanding that more, we can harness that and tap into that with some of our therapies. And so again, we're using methods that involve the MRI machine. This is a non-invasive machine. The biggest risk of this study is boredom, right? Lying in a scanner and being bored while the machine does the work and takes the pictures. So it's a very benign approach to this, and we get really well-defined pictures. We do that in the sense that we have participants do a task in the scanner. We have them speak, say ah, e. That allows us to look in the brain what regions are active during that speech. And when we understand which areas of the brain are involved in speech in the individual patient, then we can start looking using the resting state MRI. When the patient's just lying there resting, we can put a spot on that region in the brain that is involved in speech, and we can start to trace through the brain where that region connects to. And we can do that both before Botox, and we can do that after Botox. And so the idea is that we anticipate that there will be a change in how these areas of the brain are communicating in the treated phase versus the untreated phase. And so these are, I think I've got about 3 slides of preliminary data here. This shows that we are achieving our specific aim. So this slide here, in a single one-person patient in the upper left here, is the map, the actual oxygen changes, the blood oxygen changes that occurs with respect to the voice activation. And so this is relatively unique, being able to show this at this high degree of resolution in a single individual. The thing that makes this difference is this individual we've recorded for 8 hours of bold time. So that really allows us to get this spatial resolution. And so we see cortical regions. I don't know if you can see my pointer or not, but there are cortical regions here that map out in this individual. And there are also subcortical, meaning deep inside the brain regions. And these in particular are very interesting regions, because this spot right here, for instance, is a region that we stimulate with electrodes to treat various movement disorders, such as dystonia, the globus pallidus pars interna of the brain. And then also the cerebellum, which is a known area to be involved in and hypothesized to be involved in dystonia. This map up here is, again, one of our single patients with adductor dystonia that we have mapped, and it compares very much to an average map across patients that has been previously demonstrated by other groups. So this demonstrates feasibility. This demonstrates that we are able to pull out these similar regions in the individual with dystonia. And of course, it shows that there are some subtle differences in the size and the location in this individual with respect to the group. And so if you had chosen one spot, for instance, here in this group map, you wouldn't have necessarily seen that in this individual. And so this changes how we think about this and how we might approach research studies, understanding the specific regions in those individuals. This here is a map that shows the treatment effect, right? So this was specific aim 2, where we scan a patient before Botox, we treat them with Botox, they get better, and then we scan them again. And what this shows in this pre-treatment region, this pre-treatment map, is that the regions that are yellow or hot in this case are highly connected. This is the motor region that we just showed with respect to the voice when people speak. And after treatment, it may be subtle, but I'll demonstrate the effect here in just a second. That functional connectivity increases. The network, the way the brain is communicating amongst itself in the treated phase is much improved compared to where it was before the treatment. And so that suggests that this Botox is affecting these functional networks and giving us clues to with respect to which networks are important to target with respect to research, treatment, those types of things. And then this here is just the subtraction, pre-treatment minus post-treatment. You see a big difference here in this similar region that I just described. And so that gives us in this individual a map of the regions that are important in the cortex. But again, deep inside the brain, this is a slice through the brain like this, where we're looking through the brain incoming like this. This region is the globus pallidus. This very defined hot spot here, the yellow region here, is again the globus pallidus pars interna, a region that we already know responds to therapy. And so in this individual, for instance, we can now study if we place an electrode in this region, do we get an effect, and is that beneficial knowledge for us? And then again in the cerebellum here, so this is a slice through the brain looking this way, sideways into the brain, and we see the cerebellum here, and we see changes in the cerebellum as well. So perhaps not less invasive therapies like TMS or things like that might be targeted at these regions or the cortical regions we saw over here. So briefly, in conclusions, we've achieved our aims, even just showing one individual. We've now collected data on 3 individuals, and we anticipate collecting data on 5 total before the funding opportunity arises. And so we've demonstrated the feasibility with respect to the aims, and this is now already leading us into future directions and how we want to think about this data, right? And so I've shown you one person. What we now want to do is compare this across individuals. How much variability is there between myself and the next person, or the patient 1 or patient 2 with laryngeal dystonia, and how do we account for that? We want to apply this to other focal dystonias, right? Because the same principle holds true to these other disabling disorders: cervical dystonia, blepharospasm, focal hand dystonia. And do the maps have a similar construct, or does it differ when there's a task-specific versus non-task-specific dystonia, for instance? This is a technical term, lags analysis. Really, we want to apply this concept of latency to our resting state MRI. We can start to hone in on which regions of the brain, when there's altered signal like this, which regions of the brain does the signal originate in and transfer to other regions. So I've shown you that there's differences in the motor cortex, the GPI, the cerebellum. Now the question is, which of these areas might be contributing the most to the dysfunction, or is it the network as a whole? And so this type of analysis will allow us to really hone in on that. And then, of course, the biggest consideration of these data are, how do we increase our collaboration? How do we advance this to improve therapies? And so I've already suggested that these indicate potential targets of engagement with respect to therapies going forward: TMS, DBS, novel therapies coming down the line. And so these data in application for patients who they're doing DBS trials in and where they're doing TMS trials on really give us a good solid target in that single individual that we're analyzing, as opposed to just averaging across many people with a disease.